Hi, I'm Dr. Hisham Alsanawi. I'm an assistant professor and orthopedic surgery consultant here at the College of Medicine, King Saud University in Riyadh. Today we will be demonstrating some of the major tests for the body joints. This activity is arranged and sponsored by the Surgery Interest Group here at the College of Medicine. Well, in the beginning of the physical examination of an orthopedic surgery, we would like to get enough exposure to show the details of the limb. In this situation, the patient is dressed and it's difficult to evaluate his shoulder. So we need to get enough exposure. Usually we expose both shoulders for comparison. We have a complete exposure of both shoulders and the upper trunk, which is important in evaluating the muscle contour. We have the complete exposure of the back as well for the same reason. We will look at the patient from the front, looking at the contour of the general contour of the shoulder, both deltoid muscles and the pectoralis major, as well as the biceps muscles. As you can see here, the shoulders are symmetrical. The shoulder has a normal contour. Deltoid muscles are symmetrical, both sides, and the pectoralis major and biceps muscles look normal. Now, from the side of the patient, we will look at the shoulder as well, comparing the muscle contour from both sides. Looking at the deltoid, general contour of the shoulder, biceps muscle, as well as the pectoralis and the pectoralis major muscle, as well as the rotator cuff, the supraspinatus and infraspinatus muscles. The pectoralis major, deltoid, supraspinatus, infraspinatus muscles have normal contour. Now from the back, we look at the rest of the muscles to compare the contour of the rotator cuff muscles. Here we can see obviously the supraspinatus muscle, the infraspinatus muscles, teres minor, and they both have the normal contour. We compare this to the other side. They are both symmetrical and have a normal contour. Okay, now we can see that this is the scapula of the patient. You feel the borders of the scapula, the spine of the scapula, and you can see you can see and feel the contour of the supraspinatus, infraspinatus muscles. We can compare both muscle shapes of the deltoid, supraspinatus, infraspinatus, and the both levels of the shoulder. As you can see here, we can see the contour of the deltoid muscle is within normal. Supraspinatus and infraspinatus muscles are symmetrical. One abnormality we can notice here that the both shoulders are not the same level. The left shoulder is a little lower than the right one. To complete the inspection, we have to rule out any scars of previous surgeries and injuries, any skin changes, and any swellings. Now we'll try and feel for the patient's shoulder. We will start with the most medial part of the shoulder girdle, which is the sternoclavicular joint. In here, this is the sternoclavicular joint. No swelling, no tenderness. We go all along the clavicle to the lateral aspect. Here we feel the acromion and the acromioclavicular joint. There is no tenderness or swelling. The anterior lateral edge of the acromion is over here. Posterior lateral edge of the acromion is here, and as you can see, this is a squared structure where the lateral edge here is felt. Now, from the side and posteriorly, we can look at the shoulder, lateral aspect of the shoulder. Here, this is the, as we demonstrated before, this is the anterior lateral corner, posterior lateral corner, and the lateral edge of the acromion. The continuation of the acromion as the spine of the scapula is felt over here. We can, as you can see, we go medially to the medial border of the scapula. We go all along the medial aspect to the inferior corner of the scapula and the lateral aspect of the scapula over here. We can feel for any abnormal swellings or any points of tenderness. Here we can feel as well the supraspinatus for any tenderness, or if we can demonstrate any atrophy of the muscle. Inferiorly, we can feel the infraspinatus as well. To complete the palpation, we will try and feel for the temperature and compare both sides. Here we can feel with the dorsum of the hand for better feeling, and compare that with the same area from the other side. We go all around the shoulder, anteriorly and posteriorly as well. Here at the anatomy lab, we will demonstrate the physical examination of the shoulder on the skeleton, which will give a better idea of what we're doing. On palpation, we felt the sternoclavicular joint, which is this area here, the junction between the Melaibary sterni and the medial clavicle. We go all along the clavicle to the lateral aspect. Here, the junction between the clavicle and the acromion joint. The acromion is called the acromioclavicular joint. We feel this for any swelling or tenderness. Here, at the lateral aspect, this is the acromion, the squared structure here. This is the posterior lateral edge, and this is the lateral edge of the acromion. Posteriorly, we go all along the acromion to the medial side. This is the spine of the scapula. Then we can feel the supraspinatus muscle, which is usually over this area, the infraspinatus muscle here, and the teres minor. We try to feel the medial edge of the scapula, the lateral edge, and try to feel for any tenderness or any abnormal swelling. Now, as a big major part of the examination is to demonstrate the range of motion of the shoulder. As we all know, the shoulder joint has a great range of motion, and demonstrating that is of paramount importance. Here, to be able to give the correct angles, we have to know the zero angle of the shoulder, which is usually where the patient has his arm beside his body, and this is considered the zero angle. First, we start with active range of motion. The reason is to avoid hurting the patient at the beginning of the examination, so we will ask him to move his shoulder. Can you please move your shoulder forward? All the way up, please. Now, this is 180 degrees, starting from the 0 point. So this is a full forward flexion. Shoulder abduction. Can you move your arm to your side all the way up, please? So the patient has a 180 degree shoulder abduction. Move it back, thank you. Shoulder extension. Can you move your shoulder to the back? Actually this way. Try to move this way. Yes, all the way. And this is probably 80 degrees shoulder extension. For the adduction, either we ask the patient to move the arm in front of his body. Sometimes in obese patients it's difficult. We ask them to try and touch the contralateral shoulder. Try to touch your other shoulder. Excellent. This demonstrates good and reasonable range of motion, good and reasonable adduction. Now for the internal and external rotation of the shoulder, the easier way to demonstrate that is to ask the patient to keep his elbow beside his body and ask him to do external rotation this way. Can you do the maximum? Okay, good, excellent. So at this angle, starting from 0 in this position to this position, this is most probably a 90-degree external rotation. For the internal rotation, we can ask the patient to do the same thing, but then in obese patients it's difficult to do the full internal rotation. The other way to show this is to ask the patient to turn around and try and reach as high as possible at his back. Try and touch your back and go as high as possible. Here in this test, the good thing is to tell exactly what level the patient is reaching, and this indicates how much internal rotation he has. In this position, most probably he is at the lower thoracic or mid-thoracic level. Now we will start doing the special tests. These tests are special because they are trying to diagnose common pathologies of the shoulder. We will start with the rotator cuff integrities. Here we will demonstrate how to test for the supraspinatus muscle. I will ask the patient to demonstrate the empty can test. Here, patient is in 90-degree abduction, both shoulders. Thumbs are pointing downwards just to make sure that the shoulder is an internal rotation. Then 30-degree forward flexion. In this patient, he's able to maintain both shoulders at the same level. So to complete the test, we have to do the test against resistance. I'm trying to push downwards and the patient is resisting. Both shoulders are strong and he's resisting my downward push. Now, the test for infraspinatus anterior minor is to do resisted external rotation. We usually do this by asking the patient to keep his elbow to the body and then try and do external rotation. Move your this way. Okay. And then again, it's resistant to see how the muscle, how strong the muscle is. Now push outward, please. Push. It's very, very good. Now the best way is to compare both sides. Have both elbows and push outwards, please. Both. So the strength is symmetrical and it's normal. The test for the subscapularis muscle is doing maximum internal rotation and then the lift-off test. We will ask the patient to do internal rotation and go as high at his back as possible. As you can see, the level is acceptable. Then I'll ask him to lift his hand off his back and resist that and see how strong the subscap is. Here, he's able to lift his hand off his back and there's good muscle push. Now we will try and demonstrate the apprehension test. This test is to demonstrate anterior shoulder instability. A patient, we will ask him to go in 90-degree of abduction, 90-degree of elbow flexion, and then do external rotation and try and support the shoulder from the back. Keep doing the external rotation while supporting and pushing the shoulder from the back, and if the test is positive, the patient will have the fear of dislocating his shoulder. I will resist this movement. Here, the patient is freely mobile, the shoulder is freely mobile, and he has no his negative apprehension test. Impingement syndrome is a common problem. To demonstrate this, we will do the impingement, the Neer's impingement sign. We usually do internal rotation of the shoulder. This brings the greater tuberosity anteriorly, and then we go in forward flexion as high as possible. This squeezes the GT against the anterolateral edge of the acromion, and if it's positive, the patient will feel pain, or there will be a limited forward flexion because of the impingement. Another test for the impingement syndrome is the Hawkins test. Here we have the patient sitting, forward flexion in 90 degrees, then slight abduction, elbow flexion to help in internal rotation, then arm elevation and internal rotation. This brings the greater tuberosity against the anterior and anterolateral aspect of the acromion. Here, the test is negative, the patient doesn't have any pain, and this test is not hurting the patient. From a different perspective, this is the shoulder joint from the lateral side. This is the greater tuberosity. In Neer's impingement test, we do the internal rotation, bringing the greater tuberosity forward, and from there, forward flexion brings this greater tuberosity closer to the acromion, anterolateral acromial edge. When the subacromial space is narrowed, then the greater tuberosity will most probably be hitting the anterolateral edge of the acromion. In normal people, this space is wide enough to accommodate the rising acromion, the rising greater tuberosity. Another test for the impingement syndrome is the Hawkins test. Here we usually go into full 90-degree of forward flexion, slight abduction, and then we do internal rotation and elevation. The same concept, the idea is to bring the greater tuberosity and the lesser tuberosity forward and assess the subacromial space in this position. Here we go, this is the anatomical position here. Forward flexion, slight abduction, then we go arm elevation and internal rotation. Now to complete the examination of the shoulder and upper limb, we have to do the neurovascular examination by examining the peripheral nerves as well as the vascular examination of the upper limb.